Good afternoon, everyone. Welcome to our JMitra Scientific webinar titled Significance of Fertility Awareness versus Women's Health and Well-Being. We're very pleased to have with us Dr. AbhikBannerjee, Global Technical Chief for Apollo in the East. And he comes with he's a distinguished doctor with multiple decades of experience. And today he will be making our awareness, increasing our awareness on female fertility. Because fertility awareness is a pivotal goal in understanding and assessing women's health and well-being. It encompasses the knowledge and observations of the natural science of fertility through women's menstrual cycle, offering invaluable insights into her reproductive health. In general, it has been seen that women's health issues lack the attention they deserve. So fertility awareness stands out as a critical tool for enhancing knowledge, fostering empowerment, and improving the quality of life for women globally. Without further ado, I hand over the mic to Dr. AbhikBannerjee. Dr. Banerjee, over to you.
Thank you. Good afternoon, everyone. Good afternoon, JMitra entire team, and thanks for giving me the opportunity to share the platform with all of you. Today, being a laboratorician or laboratory person, I will basically focus on the laboratory investigations for assessment of fertility in women. So once we go by the slide, you will understand that evaluation of fertility or assessment of fertility is basically for the couple. We all know that it is not only a problem either with the female or the male counterpart. It's basically a problem with the couple. So ideally, as per American Reproductive Association and many other organizations, the fertility assessment should start for the couple, both the male and female partners at the same time, and equal importance should be given for assessment to both partners. So, as you all know, infertility, it is not only a medical problem, but basically we can consider this as a social problem also, because the socio-economic burden is not only on the couple itself, it also affects the family members, the relatives, maybe near and dear ones, all. So basically, primary and secondary infertility. So what are the two types? Primary means from the beginning, after marriage, if even the couple was not able to conceive. But secondary infertility means that the couple got pregnant. Maybe the first baby is live or alive, but pregnancy happened, a complete pregnancy. But then during second or subsequent pregnancy, it is not happening. So what is basically infertility? It is inability to conceive or achieve a successful pregnancy even after 12 months or more of regular unprotected intercourse. So diagnostic evaluation for infertility encompasses for couple who fail to achieve a successful pregnancy in this condition. So as we will today in this webinar consider on the female part, so basically today's lecture, my lecture will concentrate or focus on the laboratory tests which are required for the female counterpart, that means the woman. Since approximately 85% of the couples may be expected to achieve pregnancy within the interval without medical assistance. Why this is 12 months? Why it is 1 year? That's why I'm explaining that usually it is seen that with regular unprotected intercourse, approximately 85% of couples conceive or they get a successful pregnancy. So that's why, as it's a chunk of the couples, 85%, that's why consider that after 12 months, but it may be more also, right? So in spite of this regular unprotected sexual intercourse after 12 months or more, if there is no successful pregnancy, then this kind of fertility assessment or evaluation should be indicated. And that's for around 15% of the couples. Earlier evaluation is warranted. However, if the female is above 35 years of age, as the ovarian reserve or the time of the reproductive age group is very less because already she's 35. So in that case, we should not wait for 1 year. And hence the evaluation should be earlier. The testing entire process should begin early, and then it should be done after 6 months of unsuccessful efforts. Hope you understand. In a female who is less than 35, we can wait and we should wait at least for 1 year so that pregnancy may happen naturally without any testing or investigations. But if the female is over 35 years of age, then we should not wait for so much time because the window is narrow now. We have to keep time in hand for investigations and other management if required. So we should not wait more than 6 months. And usually, especially this is required when the patient is having oligomenorrhea, that means less amount, or amenorrhea, known suspected uterine tubal peritoneal disease or endometriosis. So these are special indications when we can start the investigations early, especially when the female is more than 35 years of age. So what is the global statistics? A recent report by World Health Organization released in April 2023, it is very recent, states that infertility affects 1 in 6 people globally. Please understand the overall burden. Worldwide, 1 in 6 people. Obviously, being a hugely populated country, the same largely affects India. The Indian fertility rate in 2023 is at 2. That means 2. Fertility rate is at 2. As per one recent report published in the Economic Times, it is a new epidemic. Infertility is a new epidemic of young India. 27.5 million couples in India suffer from infertility. Please understand the gravity of the situation. 27.5 million couples in India suffer from infertility. And you all know this is not only, what are the reasons? The reasons is not only use of, havoc use of the contraception. You all know that previously, decades ago, maybe that kind of contraception and those facilities were not available. But nowadays, this is also why this is fertility. But this is the maybe an informed choice by the couple that they are using contraception. So the birth rate is, is diminishing, but at the same time, the other conditions like this Western, we are adopting the Western cultures. There is stress. There are multiple different diseases like cardiovascular disease, lifestyle disorders, PCOD, polycystic ovarian disorder or polycystic ovarian syndrome, PCOS. We know, especially in Eastern India, the PCOS is like an epidemic now. So there are many causes, the junk foods and everything, many, the poor lifestyle, etc., unhealthy lifestyle, etc., obesity. These are being the reason why infertility is, the percentage is increasing globally and also definitely in India. So etiologies, what are the reasons for infertility? Causes. First, you understand that both male and female are equally actually responsible, or they may be equally the factors for infertility. They equally affect male and female, 30%, 30%. So there is no blame game. What I understand, I mean to say that only females, usually we see in our, still in our society, it is seen that if there is the couple is not being able to achieve pregnancy, then usually it's a problem with female. It's not like that. You can understand the statistics says 30% reasons with male, 30% reasons with female. There are some reasons which affect both, 10%. And there are other causes like 5% and unexplained. This is a major chunk where, in spite of several investigations, we are not being able to understand or pinpoint a definite reason for infertility. Like, for example, a male counterpart or a person and may suffer from erectile dysfunction. He may suffer from agiospermia. He may suffer from seminal vesicle block, so that this may lead to infertility in a couple. Similarly, for a female, it may be a tubal block. In our country, there is TB salpingitis, fallopian tubes is tuberculosis, endometriosis, polycystic ovarian syndrome. There are many other reasons which may lead to infertility of female. But there are many reasons which, even in spite of investigations, we are not being able to explain what is the particular reason. That's why it is called unexplained or idiopathic. We do not know. That is 25%. Please remember this slide. This will be important, these unexplained reasons, because there are some investigations where the unexplained infertility, in case of unexplained infertility, we have to do such kind of tests. We will come to the slides subsequently. So now we will focus. Overall, we saw what are the different reasons for fertility, causes of infertility. But now we will pinpoint, because the lecture here is focusing more on female infertility. So causes of female infertility. So basically, there are three causes. There are many causes you can understand. You can see here that ovulation disorder, that is the most important, that is 40%. 30% are due to tubal factors, fallopian tubes. There are many other causes like endometriosis, uterine cervical factors. But if we consider that around more than 95% are reason, 95% causes of female infertility can be categorized into these three broad categories, broad headings. Ovulation disorder. The reasons may be aging, because with age, when the female is approaching menopause, that may lead to difficulty to achieve pregnancy. Similarly, diminished ovarian reserve. This diminished ovarian reserve may happen with age. That's a natural process, because all the ovarian follicles, ovums, they are actually exhausted during menstruation, the entire reproductive life of the female. But the ovarian reserve may be diminished due to other causes also, like maybe a patient was suffering from cancer and she had to undergo radiotherapy or chemotherapy, and that side effect, due to that side effect of radiotherapy or chemotherapy or any surgical intervention, the ovarian reserve got diminished. It may be a premature ovarian failure. This premature ovarian failure is actually a problem. You can see that suddenly, due to some certain reason, the reproductive, in even a patient, a female in a reproductive age group, like maybe 20 or 23 years, but she is not being able to conceive because ovary failed, the ovarian reserve diminished. There are other endocrine disorders like PCOS, polycystic ovarian syndrome. There are tubal causes. Fallopian tubes may be involved due to surgery or pelvic inflammatory disease, previous ectopic pregnancy, and salpingectomy. Due to some reasons like ectopic or any reason, we have to remove one of the or both the fallopian tubes. So tuberculosis, PID, pelvic inflammatory disease, one of the reasons tubercular salpingitis may also happen. So any reason fallopian tube which led to stricture or any problem with the tube, fallopian tube, that may lead to infertility. And third is uterine or cervical causes. That some congenital uterine anomaly like biconjugate uterus or something like that, or atrophic uterus. Sometimes we can get a big fibroid, large fibroid. There may be endometriosis, there is adhesion, and that's why there is no successful pregnancy. There may be a poor cervical mucus quality or quantity, and there may be uterine or cervical infection. So these are the broad headings or broad category under which we can almost 95% of the causes, reasons for infertility, female infertility is there. So now we will come up with the infertility workup for a female, right? When a patient presents to an infertility specialist or an obstetrician or gynecologist that the couple is not being able to achieve a successful pregnancy for more than 12 months in spite of regular unprotected sexual intercourse, or in a female more than 35 years, it's more than 6 months, there is continuous effort but there is no successful pregnancy, the couple should be called by the obstetrician or the infertility specialty for a workup. And I again stress on the fact, insist that the couple's investigation of the couple should start at the same time simultaneously, so that the chance of a better outcome is achieved. Because if we do not know the problem is with only the male or only with female or with both, so we should start the investigation early. But here we are focusing on the female part. That's why I'm discussing about the infertility workup for a female. So for any disease, any disorder, the first approach is medical history or clinical history. That is most important. What may be the history? How, since how long they are trying, the time of marriage, the last menstrual period, any kind of contraception they are using or not, and how regular is the intercourse, whether everything is okay. This kind of medical history taking, any drug, particular drug, which may hinder with the outcome, any surgical intervention, this is medical history. Okay, any history of any other major chronic disorders like diabetes, it may be malignancy. So this kind of detailed history. Then physical examination. The women should be examined clinically or physically by the obstetrician or the infertility specialist. Then investigations. Then we come to investigations. Please remember, these investigations can be categorized into two parts: pathology investigation, that means laboratory investigations, and then the radiology. So both are equally important, because if you think, if we consider the tubal causes, fallopian tube related causes, or the uterus or cervical problem, uterine or cervical problem, as we discussed in the previous slide, then all the investigations are basically dependent on radiology, hysteroscopy, hysterosalpingography, and many other tests, dye test, as you know. All basically they concentrate, these radiological tests are basically for uterine or cervical causes or tubal causes. Yes, there are some other there are investigations like antral follicular count, like USG, also done for ovulation, etc. Hello, please call me after half an hour. There are other reasons also we can do to check the ovarian reserve and those things. Antral follicular count radiology investigations are there, but basically these radiology investigations are concentrate on the tubal reasons, tubal factors, or the uterine or cervical factors. So laboratory investigations or pathology tests are the basically used for ovary related problem, like when we are suspecting ovulation related problem as a disorders of ovulations or related to any ovarian reserve. So all these investigations are the cornerstone for establishing the cause of infertility. So be it pathology or radiology related tests, these investigations are the cornerstone for establishing the cause of infertility. So again, the indications for fertility testing, we are slowly coming to the laboratory tests. So first indication, as we already discussed, inability to conceive after 12 months of regular unprotected sexual intercourse, or in a female of more than 35 years, it is for 6 months. Okay. Then the second point is we may have to test for this fertility in case there is diagnosed reproductive system issues like fallopian tubes, ovaries, or uterus. We all know that there, by clinical examination or by history taking, we understood that there is some problem related to fallopian tube, ovary, or uterus. And then to support that clinical findings with documentary evidence, we have to do these investigations. Third, there might be some known menstrual disorders like oligomenorrhea, amenorrhea, when the patient is already complaining that yes, I am having oligomenorrhea or amenorrhea. I have to then do the test. There is history of recurrent miscarriage. The patient, see, infertility is basically inability to conceive. But if it's a case of secondary infertility, that means initially she got a successful pregnancy, but after then they are trying, but they are trying repeatedly, but somehow in the second trimester or first trimester there is recurrent miscarriage. Then also we can go for the fertility testing. Then there is documented history of pelvic inflammatory disease, pelvic pain, or endometriosis. To support the clinical findings, we have to do that fertility testing. And partner with suspected or identified male infertility. When we know that it is possibly a male infertility, but still we should do the test for female, because the reason, the cause of infertility may be for both also, because a good percentage of infertility affects both the partners, and also maybe to rule out that there is no problem with the female. So these are all the indications for fertility testing. If you have any problem, you can mention in the chat box. If you have any questions, you can mention in the chat box. I can explain after the session. So this is the very important slide. Please go through the same minutely and very carefully. This is the diagnostic approach when a woman is presenting with the infertility. First is history and examination. See, laboratory investigation is always to support the clinical findings or clinical suspicions. Okay, and it's an era of documented evidence, right? We cannot just tell that yes, the female is having a poor ovarian reserve, so that is the reason for infertility. We have to document that through our laboratory reports, because 70% of the more than 70% of the clinical decisions is guided by laboratory investigation report. So that's why it's a cornerstone. As I told, it's a cornerstone for assessment of infertility investigation. So after history and examination, if we get to know that patient is having normal menstruation, so then still there is infertility, but normal menstruation, then what we have to do, that we have to understand whether the patient is ovulating or not. Okay, so that we have to understand. So for that, we have to measure the progesterone. This is a test, serum progesterone, and usually we measure it in the mid-luteal phase, that is day 21. If the progesterone is more than 30 nanomole per liter, then the patient is ovulating. If there is ovulation, then the chance of pregnancy is very high. So then we have to investigate further, because the patient is ovulating. There is no problem in that sense. But if it is, the progesterone level is less than 10, then the patient is most probably not ovulating. That is very important. So we are telling about normal mens, when the patient is giving history that yes, my menstrual cycle is regular and periodic. Okay, and amount is also, there is no problem. But if the patient is giving a history of amenorrhea, that is no menstruation, or oligomenorrhea, that is less amount or less duration, then we have to perform the pregnancy test, because in pregnancy also there may be amenorrhea. Okay, but if there is pregnancy is positive, then we have to counsel the patient that it is not infertility. Already you have congratulations that you have already achieved a successful pregnancy. So just you have to continue. So there is no further test is required, because it's a fertility evaluation. But if the patient is negative for pregnancy test, that means patient is having amenorrhea or oligomenorrhea, but there is no pregnancy, then there may be some problem. Or patient is not ovulating. First test is progesterone, not ovulating, pregnancy is negative. We have to do a LH, FSH, and prolactin. This chart or this diagnostic approach is very, very important. Why I have included this? Because this simplifies your investigation protocol and your understanding. So then we have to do a LH, FSH, and prolactin. If there is high FSH, we all know if the follicular stimulating hormone is high, okay, there is, we can document that patient is having ovarian failure, because we all know that either in premature ovarian failure or when the patient is approaching menopause, the FSH will be high. But if the patient is having high LH, okay, and FSH is not low, I will say sometimes it is low or it is near normal or it is normal, then we can say the patient is suffering from polycystic ovarian syndrome. So please note this diagnostic algorithm. This is very high. Only from doing progesterone, LH, FSH, these are the basic, very basic tests, you can almost pinpoint the diagnosis. But if the patient is having high prolactin, then further investigation is required. Usually, please remember, prolactin is not the first test. If you have done all these tests, progesterone, FSH, LH, everything is okay, and you are getting some history that patient is having galactorrhea, that means milk-like milk secretion. Patient is non-pregnant, but still milky secretion from the breast, or patient is having some headache or something like that, and she is having prolactin, high prolactin, then we have to investigate for hyperprolactinemia. We have to, not a single test of prolactin, because the prolactin has a diurnal variation, so we have to test whether the prolactin is really high or not. Any medication is going on which is falsely giving rise to high prolactin. But after that, once we suspect that yes, the prolactin level is really high, in spite of subsequent testing, we have to go for further testing. Maybe a MRI of pituitary or brain is also suggested, because it may be a prolactin secreting tumor, or it may be a pituitary macroadenoma, or something like that. But if everything is normal, LH, FSH, prolactin, these are the basic tests, progesterone, LH, FSH, you have also excluded prolactin, hyperprolactinemia, everything is normal. If all these tests are normal, then further tests are indicated. What are the further tests? Maybe the test for ovarian, to check ovarian reserve, or the secondary test, or other investigations, which I will explain in subsequent slides. But this is the very basic part, but very, very important. The baseline investigation, the initial investigation, you should call for every patient who are coming to you in your chamber with a complaint of infertility. So these are the laboratory investigations. As I told, the laboratory investigations, if we consider the radiology part, that basically focuses on the tubal parts and the uterine and cervical regions. But if we consider the pathology based or biochemistry based tests, they basically concentrate on ovarian function. So it's maybe due to assess the ovarian reserve, that is basic. The best tests are AMH and FSH. Okay, and if we consider that it will be suspect an ovulatory dysfunction, then we should do the other tests like progesterone, as I told, LH, FSH, etc. You can do the PCOD related test, next slide, and TSH, prolactin, etc. Okay, as I told, because PCOD related test means LH, FSH, etc. If LH is high, FSH is near normal or low, then it may be a PCOD. If progesterone is less than 10, it may be anovulation. We have to then investigate accordingly. Patient may need ovarian stimulation, etc. We have to also do some tests like TSH, because hypothyroidism, if it remains untreated, a patient of chronic hypothyroidism untreated, they may also land up in infertility problem. So we have to correct the hypothyroidism with L-troxin or thyronome supplementation. So these are the basically laboratory investigations which are required for fertility assessment, categorized into ovarian reserve and ovulatory dysfunction. Ovarian reserve is said to be poor if AMH is less than 1 nanogram per milliliter. We all know if the AMH is less than 0.3 nanogram per milliliter, usually we can say the possibility of pregnancy is almost nil. Okay, so AMH level is less than 1 nanogram per milliliter, ovarian reserve is said to be poor. This is very important test for the infertility specialist because they can counsel the patient accordingly that if it is as it is less than your AMH is less than 1, the chance of successful pregnancy is very less, but still we will try with IVF, in vitro fertilization techniques. The FSH is greater than 10. As I already told, if FSH is more than 10 or AMH is less than 1, that means patient has very poor ovarian reserve, patient is approaching menopause, or it's a premature ovarian failure, right? So basically for ovarian reserve, we should do this test. But first, when the patient comes with infertility, first you do the progesterone, LH, FSH. These are the basic tests, TSH and prolactin. If you find out the cause, very well. If you do not find out the cause, go for ovarian reserve testing, AMH, FSH, right? And for ovarian reserve, you can also do a radiology test. Here I am not discussing about the radiology, but I can tell you the antral follicular count. This is an USG ultrasonography based test that should be done. But for pathology, we will concentrate for AMH and FSH. So for ovarian, assess ovarian reserve, when we will do that, unexplained infertility. When we are doing the progesterone, LH, FSH, everything, and we are pinpointing the cause, that's very fine. It may be an ovulatory dysfunction, but or a hyperprolactinemia or a hypothyroidism. But when we are not being able to understand what is the problem, there is everything is normal, then we should go for an ovarian reserve test by AMH, FSH. So that is the reason. And also in case of unexplained infertility, when you are not getting any reason, we have to do, because we have to rule out that patient's ovarian reserve is good, because unless patient's ovarian reserve is good, the chance of successful pregnancy is very, very limited. Then age 35 or older, we can also do this kind of ovarian reserve AMH, FSH testing, whether the family history of early menopause, because if the patient's mother, etc., are having early menopause, we can do this AMH, FSH, we can assess her ovarian reserve, and we can counsel the patient that, see, you are also approaching menopause, so you have to try for pregnancy as early as possible. Previous reproductive surgery, because what happens during surgery, your ovary or fallopian tube your ovary may get damaged, or chemotherapy, your ovary may get damaged, and subsequently you may lose your ovarian reserve. Okay, having only one ovary, previous gonadotropin induced ovarian stimulation, that means this is actually IVF. When there is ovarian stimulation by clomiphene citrate, you have to assess to monitor the response to therapy, you have to do a AMH and FSH testing also. So then this is very important. When you will do this test, please remember LH, FSH, estradiol, prolactin. All these tests, usually they are done they are menstrual cycle dependent. So you should do this test in between 3 to 5 days of cycle. So what is the importance? Sometimes see these you get as a panel testing, right? Progesterone, LH, FSH, estradiol. Usually these tests are collected at 3 to 5 days. So if you are unable to give the report, please understand valuable time is wasted, because again the clinician need to wait for the next cycle, 3 to 5 days. So please train your phlebotomist technicians or accordingly, so that it's a precious sample. So they have to collect the sample properly so that there is no hemolysis, there is no leakage of the sample or anything, because it's a valuable sample. And you all know, in a patient who is already approaching infertility specialist for IVF therapy, the time is honey. Time is very, very important. So laboratoricians, being a laboratory person, these are responsibility that we should handle the samples very well and very carefully with responsibility. Progesterone, as I told, it should be done at the mid-luteal phase, that is day 21, and you can check the ovulation status. If it is less than 10 nanogram per meter, then it's anovulatory cycle, anovulation. If it is more than 30, then definitely there is ovulation is happening. But what is the novel test, that is anti-Mullerian hormone, which is basically done for ovarian reserve. You can understand the advantage of AMH over other tests. Okay, even if you are selected, if you are given a selection, the choice that which test you will do, AMH or FSH for ovarian reserve, then you can select AMH, though it's a costly test, but AMH is best. Why? Because it is not cycle dependent. At any point of time, at any point of cycle, you can menstrual cycle, you can collect this AMH test, because this does not have a cycle to cycle, the time to time variation. It will give a consistent result, whatever it is. So AMH can be collected at any time of the cycle, any day of the cycle, but rest of the test should be time dependent or day of cycle dependent. Progesterone mid luteal, that is 21 days. Rest of the in the follicular, early follicular phase, that is 3 to 5 days. So interpretation, I have already told. Just for basic understanding, please remember, because PCOS is very, I mean, it's a very common cause for infertility or ovulatory dysfunction. So if LH is more and FSH is near normal or low, then it is a PCOS. Usually it is said that LH FSH ratio, if it is more than 2:1, LH by FSH ratio is more than 2:1, it is usually suggestive of PCOS. I am not saying it's a confirmation, but suggestive of PCOS. Ultimately, PCOS is a syndromic diagnosis. You have to multidisciplinary diagnosis. You have to do USG sonography to check the bilateral polycystic ovaries are there or not. You have to check whether the patient is having high AMH, high LH, low near normal or low FSH. There are other symptoms like oligomenorrhea, amenorrhea, etc. So this a so not a single test is enough. But still, as an overall thumb rule, you can say LH high, FSH low or near normal to more than 2:1. LH by FSH ratio is suggestive of PCOS. Both LH, FSH, that's normal. And decreased ovarian reserve, what will happen? You all know FSH will be high, LH will be normal, near normal. Okay, so ovarian reserve, decreased ovarian reserve, that means patient is approaching menopause or patient is having a poor reserve. How? FSH will be high. Simultaneously, if you do the AMH, AMH also will be very low. AMH low and high FSH is up, help you to pinpoint the diagnosis of decreased ovarian reserve. So as I already told, for ovarian reserve, to assess the infertility, if you want to do the AMH, if you have to select the test, the AMH has distinct advantage over others because it does not change with the over the course of menstrual cycle. FSH should be collected in the early follicular phase like day 2, day 3, day 3 to 5, but AMH can be collected at any point in time. AMH, they actually they correlate very well with the antral follicular count. That is a radiology based investigation. Okay, and AMH levels are relatively very stable. They are not affected by menstrual cycle, smoking, pregnancy, body mass index, etc., which actually may affect the results of other hormone tests like LH, FSH. Okay, so AMH concentration can even it is sometimes it is called, if it is done correctly in a proper reputed laboratory with good quality control, AMH concentration could reliably almost equally predict the ovarian reserve status compared to antral follicular count. Okay, almost they are similarly effective. And also in IVF cycle, actually IVF patients of IVF, AMH is the best test. They mostly rely on AMH concentration. They do not rely on the rest of the hormonal tests because they have fluctuations, but AMH is relatively very stable. They basically concentrate on AMH and antral follicular count. Okay. So these are the characteristics for a good marker. See, the prediction of poor response like AMH. If AMH is very low, AMH correlates very well. AMH is, if it is AMH correlates much better than antral follicular, almost equally to antral follicular count, but they are a better indicator rather than FSH for prediction of poor response to IVF therapy. Okay, so because it has a low intracycle variability, this may be done in all patients. Okay, that is very important. And yes, but the only problem is, yes, AMH is costly. When you are getting LH, FSH, these tests are in market around 500 to 600 rupees, like 450 to 600 rupees, but you can get the AMH is around 2500 or 3000. Okay, so definitely AMH is costly, but otherwise for ovarian reserve assessment, AMH is the best test in comparison to other hormones like FSH, estradiol, or inhibin. So these are another hormone, inhibin B. You must have heard inhibin A. Inhibin A is different. It is actually for the Down syndrome, quadruple marker test, maternal marker. Basically here, inhibin B is basically for fertility assessment. Inhibin B is actually like an AMH. It is almost the same like AMH. If the inhibin B is less, then it is usually indicates that it's a poor ovarian reserve. Okay, this also like AMH, it gives an idea about the ovarian reserve, the egg quality and egg quantity of a female. Okay, and usually inhibin B is similarly used for in vitro fertile cycle, but nowadays inhibin B has largely replaced by AMH because AMH is more stable and more better parameter. However, still sometimes deaths in even B test is asked in a for unexplained infertility, patient over age of 35, same indication like AMH, but still I will say that largely it has been replaced by AMH testing, because cycle to cycle, over cycle variation is almost nil in case of AMH, but in even B has some problem, you have to again do the test on day 3 usually. So there are some key notes regarding the lab test. You all know FSH obtained on cycle day 2 to 5 is commonly used as a measure of ovarian reserve along with AMH. High value has been associated with failure to conceive. In women with amenorrhea, a patient is coming with amenorrhea, okay? Pregnancy has been ruled out. There is no pregnancy, but still she is having amenorrhea. So we have to do then FSH and estradiol measurement. If it is ovarian insufficiency, poor ovarian reserve, then it will be high FSH, low estradiol. Similarly, AMH will also be low. But if it is a hypothalamic amenorrhea, like it's a problem with hypothalamus, then what will happen? Because pituitary is not secreting hormones, so you will get a low FSH, low estradiol. So if it is high FSH, low estradiol, it is a poor ovarian reserve. But it's a hypothalamic amenorrhea problem with pituitary gland hypothalamus, then you will get a low or normal FSH and low estradiol. In those women with normal FSH and estradiol levels, in the setting of patient is having oligomenorrhea and ovulation, you have done a progesterone and there is evidence of anovulation, patient is giving a history of oligomenorrhea, then still you are getting normal FSH estradiol, then what you should think about PCOS. And then how you will diagnose PCOS, you will do a LH FSH. FSH will be normal, but LH will be high. And you can also do a AMH, because AMH in PCOS is usually more than 6.9 or more than 7. Okay. So if you are getting a normal FSH estradiol level in setting of oligomenorrhea and ovulation, you should evaluate for PCOS. As I already told, LH-FSH ratio more than 2 is suggestive, but neither highly specific or specific for PCOD. But you can get an idea that patient may be having a cause of suffering from PCOD. You can correlate your clinical findings along with USG multicystic ovaries. But from basic LH-FSH, you can get idea about what is the problem, whether it is an hypothalamic amenorrhea, whether it's a poor ovarian reserve, whether it's a PCOS, you can diagnose all from. Apart from this basic test, we have AMH, definitely. As I already told, AMH is usually significantly higher in PCOD cases. Usually in ovulatory conditions, including PCOS, AMH is more than 6.7. Okay. So AMH is almost undetectable, less than 0.3 nanogram per milliliter near menopause, and any AMH value less than 1 indicates poor ovarian reserve. Yes, you have to do some other tests, as I already told, like TSH, because untreated hypothyroidism may lead to infertility. Prolactin is not recommended as a part of routine infertility evaluation, but yes, when everything is normal, like you are getting a normal LH, normal FSH, normal progesterone, but still patient is not having some problem, you can always do, you should rule out hyperprolactinemia by doing a prolactin test. Also, patient may give history of milk secretion from the breast in absence of pregnancy, galactorrhea. So now one very important, this is a practical why I'm giving, because you are practicing in laboratories or hospitals in day-to-day scenario. Sometimes it happens that there is a AMH and FSH discordance. Okay, sometimes we will not get because AMH is low, FSH high. This is a typical picture of poor ovarian reserve. But sometimes you sometimes see a patient that AMH is low. Okay, so FSH is not high. So the gynecologist complained that your report is wrong. AMH is low, and I am getting a good antral follicular count. Patient is not at all a poor case of poor ovarian reserve, because antral follicular count is very good, so more than 6 to 7 follicles per ovary. But why I am getting a low AMH? This is a very, very important case. Please remember that usually AMH value is usually it is not dependent on cycle. It is a very robust, very stable parameter. But if the patient is suffering from hypothyroidism since a long time, which is untreated, or patient is suffering from chronic vitamin D deficiency, you all know that vitamin D deficiency is very much endemic. It's in India. Everyone is having low 25 hydroxy vitamin D, poor low level. Everyone is suffering from that. So if a patient is suffering from these two conditions, chronically since a long time, untreated, poor level of vitamin D, 25 vitamin D, or very high TSH, untreated, okay, then AMH may be falsely low. So in such cases, you have to correct the vitamin D deficiency, and you have to, or if it's a patient of hypothyroidism, you have to correct with L-troxin supplement, then AMH will be automatically normal. So please remember, false low AMH, it is a documented thing. Uh, it is very much well published. You can check Google, you can check papers that chronic vitamin D deficiency and hypothyroidism, which is untreated, may lead to false low AMH. So wherever your results, AMH results is not correlating with anti-follicular count, before telling my report is wrong or something like that, please advise the gynecologist to check the vitamin D and TSH status. If there is any problem, please correct that and repeat AMH. Your AMH will be normal. Okay. Sometimes a increase AMH value than expected, that may also happen. There are some other reasons, but please, these are the 2 points, very, very important. I'm categorically mentioning this because this happened with me when I was working in a pan-India laboratory in Mumbai. The infertility specialist repeatedly complaining about that AMH reports are wrong. She's a very reputed, known infertility specialist. But I told that everything is normal, madam. Please, for these 5 patients, you do a vitamin D status 25, and she later on accepted that yes, after vitamin D, they are having low vitamin D, and after supplementation with vitamin D for 1 month, they got a normal AMH, and then she was satisfied. Similarly, hypothyroidism untreated may happen that you will get a falsely low AMH value. Okay. So these are the test methodologies, as you understand. Yes, these are hormones. So as I repeatedly, I'm insisting on the thing that you being a laboratorician, it is your utmost responsibility, because in laboratory, garbage in and garbage out. If you whatever the instruments you are using, but the sample quality is not proper for a hormone analysis, the entire thing, the purpose is lost. If your sample is hemolyzed, if your sample is not having a proper temperature maintenance, the cold chain is there is a breakdown in cold chain. If you cannot maintain this kind of robust quality control, pre-analytical quality control, the purpose of testing is entirely lost. So please be careful about your sample quality, especially when you are dealing with hormones, these AMH, LH, FSH, progesterone, etc., because these are heat labile. These are very fragile parameters, fragile analytes, which may be deteriorated. The samples will be deteriorated, and you can get a falsely low result, and the effect on the patient is detrimental. Okay. Similarly, you should have good testing platforms also, hormone testing. If you are dealing with a steroid hormone like testosterone, estradiol, then you should, the gold standard is tandem mass spectrometry or LC-MS. But for LH, FSH, AMH, these are the basic tests, progesterone, these things, basic tests, you should have CLIA or ELISA based platform. But I must repeat that many labs are using ELISA, but CLIA or chemiluminometric immunoassay is much, much better than ELISA. The reason is it's a fully automated technology, first of all. So ELISA, manual ELISA is actually, this is a problem, because you need a very expert, good technical hand. The pipetting is very, very important because you are doing it manually. So manual error may happen with manual ELISA. It's human dependent. But CLIA, it's a fully automated platform. So use any good quality instrument. That is not a problem. But US FDA approved assay, the machine should also be good quality. And at the same time, whatever reagent or kit you are using, please remember that you should have not a research only use kit. It should be a US FDA approved assay for in vitro testing. IVD, in vitro diagnostics, and the test should be enhanced sensitivity. When you are selecting your machine, when you are selecting your reagent kit, please check that what is the lower limit of quantification, LOQ, what is the analytical measurement range, because in case of anti-Mullerian hormone, progesterone, LH, the lower limit of sensitivity matters, the LOQ, because sometimes the patient is going through infertility treatment, IVF cycle, they want to know the exact value. So whatever platform, whatever the machine or reagent actually can give you the lower limit, lowest value with much precision, with much accuracy, please select that kit, reagent kit, or that instrument. So it is not a very easy thing, and please do the proper validation of tests. So benefits of automation and CLIA over ELISA, pre-analytical error due to manual ELISA, pipetting error may happen, improves operational efficiency. The turnaround time will be faster in an automated machine, obviously. And there will be high accuracy, better sensitivity, lower limit of quantification will be much less. You cannot achieve that LOQ with a manual ELISA, right? But you can achieve that with high degree of automation. So we all know that this is the problem with ELISA. But before, initially, we didn't have any option. We had to do ELISA because there were no good quality machines. The CLIA is relatively a new technology. But now, as you have already this CLIA in market, there are many machines. Please identify, please select a good quality CLIA or platform and reagents so that you can give justice to your patient, you can give better results, because overall for this hormone and hormone analysis, CLIA is a almost a robust, it's a very good technology. And even you know that you can discuss with your gynecologist, obstetrician and fertility specialist, they also want the reports, laboratory reports which have been tested by CLIA. So please select CLIA chemoimmunometric assay for your hormone analysis. You all know that even there are many companies in the market, but I would, as I'm discussing over here, the JMitra has also come up with this CLIA 181 analyzer. They have come up with this new analyzer. You can check, check demonstration. You can get the demonstration with the help of your JMitra personnel available in your laboratory, or who are in touch with you. Please check the instruments. The instrument is but please remember that we have to do a method validation. Whatever the manufacturer has claimed in his reagent kit insert, you have to verify that. That is important in your laboratory by doing a precision test, accuracy test. That is a separate session we will discuss. But choose CLIA and US approved reagent kit and assays. So these are some of the panels which are usually available in many good quality laboratories, like PCOD evaluation, screen fertility with AMH, without AMH. So all these tests have been covered, which we have discussed. There are additional tests like lipid profile, HOMA-IR, etc. Because usually it is seen that in PCOD or PCOS patients, patient is suffering from androgen resistance, or patient is having diabetes mellitus or other problems. So otherwise, you can do this kind of basic tests, as I told, LH, FSH, progesterone, prolactin, TSH, and then you can go for tests for ovarian reserve like AMH. Thank you. If you have any questions, you can, I think you have been able to understand. Somebody has questioned, have you ever come across a situation where the LH, FSH, prolactin, AMH results are varying on different platforms? If yes, can you? Yes, see, this is a very good question. LH, FSH, prolactin, first of all, whatever the patient should be advised to select only one laboratory, which one is reputed and good quality laboratory. For this kind of hormone test, you should not change the platform of testing. So if then it is a problem with the correlation, because here it is usually monitoring and progress of treatment. So if today you have done from, like for example, from one X laboratory, and they are testing with ELISA, and tomorrow you are using another laboratory which is testing on CLIA, the reference range, the value, the reagent dilution recovery, and everything gets changed. There is a reagent to reagent platform specific bias, that method to method bias, that we have to understand. So please follow only one good quality laboratory and do the sequential testing from that laboratory only. But yes, you prefer CLIA method. Those labs which are using CLIA, you can go with that lab. And thirdly, yes, AMH, previously we faced many issues when AMH came, maybe a 5, 6 years, 7 years, 10 years back, because it was having lack of standardization. Some people were using ELISA, some people were using alpha, enzyme fluorescence, and some people were using CLIA. So different methods, different. So AMH, standardization of AMHS is very important. So whenever you are doing, you are starting the test, please don't take it casually. As I'm repeatedly telling you, have to do a method verification in your lab. The manufacturer is claiming that your CV percentage for level 1 control, level 2, etc., 5%, 6%, but you have to verify in your laboratory in your setting. What is the accuracy? You can check with accuracy. You can do study with interlab study, interlab correlation. You can do, measure your retained proficiency testing sample, but this validation should be very good. So yes, this is a correct question, that platform to platform or method to method bias, this variability exists, especially for AMH. So you have to select one laboratory so that there is no problem. Good quality laboratory. Don't change. Which third-party control do you suggest for fertility markers? See, this is not a, I should not, I'm not sure whether I should tell like that, but there are many good quality companies we know. Either you can use Bio-Rad third-party control, you can use Zandox, whatever. We are using in my lab, actually, I have worked in different laboratories earlier also. Now, currently, we are using both actually. We are using Zandox third-party for immunoassay control. We are also using Bio-Rad third-party control. The variation in report across the labs are raising doubts. So that's why I'm telling. So you have to select a good quality laboratory, because you have to understand that the CLIA method, whether they are using or not, how robust quality control mechanism they are using. And please remember, variation is not due to analytical. I can tell you with guarantee, most of the variation happens due to poor sample quality. Hormone samples are very, very precious. Please first concentrate on the pre-analytical aspect. Most of the laboratories nowadays are using fully automated methods, CLI technology, everything, best quality reagents, etc., machines, etc. But what is lacking? Lacking is sample quality. How many labs are giving importance on the pre-analytical sample quality control? The sample was collected at 8 a.m. and you are getting the sample at 5 p.m. in a reference laboratory. There is no cold chain, there is no ice pack, nothing. I have seen this kind of thing. There are camps have been arranged, health camps in a doctor's chamber from an infertility specialist. You are collecting the samples. The samples are lying in under the sunlight directly. There is no ice box. There is nothing gel packed. And when they get the sample at evening, you are testing. You are giving the report. They are falsely low. So please give importance on the sample quality repeatedly. I say in all my topic lectures and talks that theoretical variables are responsible for 70% of the lab errors. First, you give importance to your sample quality. Then you should be careful about your day-to-day quality control, IQC, internal quality control. What is your ECAS performance? Please do not, even if there is a single IQC outlier, please do not entertain that. Do not run patient sample unless you do a root cause analysis, you do a proper corrective action, preventive action, you document that, and then once it's rectified, then only you run patient sample. At any situation, do not run patient sample without in a QC outlier situation. Similarly, if your proficiency testing results are outlier, please properly investigate, correct your problem, and then only there is importance of machine maintenance. Please do not forget to do your daily, weekly, monthly maintenance as per manufacturer's guideline. I have seen many machines are not calibrated. When I go for audits, many machines have overdue preventive maintenance. The manufacturer suggests once yearly PM, but due to monetary issue or whatever, they are not doing PM. The calibration, they have waived off the calibration. They have not done the calibration. Reagent lot-to-lot verification. These are important things we cannot discuss in a single lecture. But reagent lot-to-lot verification, where we are getting the change in reagent, please do a lot verification as per NABL 112 and ISO 15189. Okay, you have to run a previously written positive and negative sample. So these are the thing. If you give importance on your sample quality, if you give importance on your daily, weekly, monthly maintenance and preventive maintenance of your machine, you do proper validation before commissioning the test, you will get a good result. And you can be very much sure about your laboratory report quality. Please participate in commercial ECAS programs. These are available, widely available for immunoassay ECAS program. Please participate in that. Thank you. Nowadays, the companies are providing inbuilt control. Can we consider for so inbuilt control? That means they can have their first party control. That means the same company is giving control. I always recommend for third party control. ISO 15189 always recommends for third party control. Try to go for third party control because that is reagent they do not have third-party control and unbiased to reagents or platforms. They do not know Siemens, they do not know JMitra, they do not know Roche, they do not know Abbott or Biomeru. Okay, it's a reagent specific bias is not there. So try to use third-party control. But yes, if you cannot have that due to cost constraint or very low volume, you can use first-party control. But it is always recommended to use third-party control. Thank you. If
thank you very much, Doctor.
Question, yes.
Thank you very much, Dr. Banerjee. That was very, very informative. And given the nature of issues that surround female infertility, and I think we've just scratched the tip of the iceberg today, where we looked at certain parameters and how they are relevant. Whether we look at it from a testing perspective, whether we look at it from an analytical or a diagnostic perspective. But yes, I think that, like you said, it's not just the methodology of testing that's important. It's also the testing itself, the sample preservation, the timing of the sample. All of these things get taken into consideration to ensure that you get the right result. I'm reminded deeply of a doctor called Dr. Atul Gawande. He is in the US, and I happened to read his book, The Checklist Manifesto, the other day. He said, if you work with a checklist, everything works out fine. I'm sure in your lab you have SOPs and you have checklists as well. But if other labs are able to enforce checklists and follow processes and procedures the way you detailed it, I believe we are looking at a brighter future in terms of diagnosing female infertility. Thank you very much, Dr. Banerjee.
Thank you.
Thank you for your time, and we look forward to further discussion with you. And hopefully,
thank you.
we look forward to having you do your analysis on our fertility markers for the clearance. Thank you, sir.
Sure. Thanks for
Thank
giving me the opportunity. It was really a lovely interaction. Thanks for arranging this kind of session. Thank you. Look forward. Bye.
Bye. Thank you, everybody. We will join you in the next 2 weeks, 2 weeks from now, and we will have our next subject on the subject of celiac testing. Thank you.